So, um, Good afternoon. I am Dr. Alexis Lapuata from the University of the Philippines, Philippine General Hospital, to present a case of tuberculous cervical necrotizing fasciitis in a 42-year-old male diabetic. This is the facade of our institution, the Philippine General Hospital, one of the largest tertiary referral centers in our country, located in Manila. Last September 2021, we received a 42-year-old male with a chief complaint of non-healing wound at his left lateral neck. 3 weeks prior, he noticed a 1 by 1 by 1 cm pustule at his left lateral neck, which he repeatedly scratched, eventually ulcerating, spreading to his posterior neck and auricular area with associated erythema and purulent discharge. He was not a known diabetic. The patient underwent pulmonary TB treatment last 2019, but had no other comorbids. The rest of ancillary history were non-contributory. He was awake, ambulatory, and had stable vital signs. There was an 8 by 8 by 7 cm area of ulceration with purulent discharge at his left lateral neck and posterior neck with areas of erythema and induration. The oral cavity revealed whitish adherent plaques at the lateral and anterior aspects of the tongue and soft palate that could not be scraped, as well as carious dentition. The rest of the oral PE was non-contributory. Our initial impression was an abscess formation of the left lateral and posterior neck, oral candidiasis, as well as an immunocompromised state, probably from uncontrolled diabetes mellitus. Neck, chest, and temporal bone CT scan with contrast revealed irregular fluid collections seen insinuating within the posterior and lateral neck, collectively measuring 15.6 by 14.9 by 12.5 centimeters, with areas of beginning air pockets scattered throughout the neck compartments. The left IJV could not be appreciated, although I think it could be compressed, so it's not visible. It's this one on the right. There were no signs of mediastinitis. There was thickening of the left pinna, but the rest of the external, middle, and inner ear were unremarkable. Fasting blood sugar was elevated, as well as glycosylated hemoglobin. WBC was markedly elevated as well. HIV screen was negative. We revised our assessment from purely an abscess to cervical necrotizing fasciitis of the left lateral and posterior neck with abscess formation and type 2 diabetes mellitus uncontrolled, and oral candidiasis, as well as multiple dental caries. And this is the corresponding plan. Our patient was also started on piptazo and vancomycin by the infectious disease service and on insulin by endocrinology. He underwent debrima and abscess drainage 2 days later. This is the left lateral view, pre-op, and multiple layers of necrotic fascia and were cut until we arrived at a healthy bleeding wound bed. We could no longer delineate any discernible structures. We evacuated 300 cc of foul-smelling purulent material, sent for culture and AFB studies. Posterior view, post-op. A day after, we were able to express 100 cc of purulent discharge bedside. The final AFB studies were positive, and these were the other organisms cultured which were carbapenem resistant. The patient was started on anti-TB regimen, isoniazid, rifampicin, pyrazinamide, and ethambutol. At day 3 post-op, the swelling at the left lateral neck, you can see that the pinna has already dropped. The swelling at the posterior back has markedly decreased after drainage. There are still areas of necrotic tissue, however, and active purulent discharge, as well as necrotic fascia, the yellowish fascia. So again, on admission, and 3 days after debrima, or hospital day 5. 5 days after the initial OR, we brought our patient up again for a second debrima. This time, we decided to apply a low-cost negative pressure wound therapy. We also added odontectomy to prevent any possible instances of neck space infections because of carious dentition. So pre-debrima again and post-debrima. We again, there is less yellowish necrotic fascia in the field, and we again sent for cultures. Posterior view. Negative pressure wound therapy or vacuum assisted closure is expensive in our country. It's around $240 to 320, depending on the size of the foam. So we decided to adapt a low cost vac being used in our institution, utilizing these materials. So these are the materials. This was consulted with the plastic surgery service in our institution, as well as adapted from Ranjit et al., published last 2012 on modifying negative pressure wound therapy. They used saran wrap, but anything that will seal the wound by attaching to the skin will do. They are orthopedic surgeons, so this experience was for upper, lower, and back wounds, and we used iodine dressing. So this is the wound bed in red. We cut the sponge to follow the contour of the wound bed. It's important not to extend the border of the sponge to beyond the wound edge. And we cut a small, and then we cover the area with iodine dressing to maintain a seal. We cut a small hole in the iodine dressing and also on the sponge, just a small hole. We thread a suction catheter or suction tubing, and we secure the tubings with any adhesive. We use Tegaderm, then turn on the suction. So this is the negative pressure turned off, and then this is it turned on. Take a look at the sponge, compare the left and the right. So this one is not collapsed off, and you can see that it's collapsed here. We changed the negative pressure wound therapy at hospital day 12. You can now see the wound bed to be more pink with areas of beginning fibrin formation. Pay attention again to the wound edges. And this is the scan, September 20, October 4. There is decrease in the soft tissue density and the rib enhancing areas. And then this is the defect in gauze. We set the dressing change arbitrarily at 3 days first. The wound edges appear to contract more. Granulation tissue is increased. And this is posterior view, October 2 wound edges. The skin is also re-epithelializing. Around the 33rd hospital day, we decided the wound bed was well granulating, or after 27 days of NPWT, cultures turned out negative. We decided to proceed with split thickness skin grafting, lateral, posterior view. The Zimmerman dermatome we borrowed from our plastic surgery colleagues. This is being meshed. This is the end product. This is the harvested skin graft and stapled. We also applied non-adherent wound dressing because we wanted to utilize the negative pressure wound therapy instead of bolster dressings to make the skin graft adhere. So cervical necrotizing fasciitis, neck fascia usually affects the extremities, thorax, abdomen, and groin area. It's a fulminant infection affecting superficial layers of the neck. This is the most common cause, while skin trauma is not unheard of, which is what likely happened in this case. These are the risk factors, type 2 DM being the most common for lack of immunocompetency. It may mimic a deep neck abscess, but these signs point toward cervical neck fascia. So we saw in the CT scan a while ago pockets of air. Serial surgical debridement is the mainstay, and multiple trips to the operating room are often required. Urgency is key. We don't want the infection to progress to the mediastinum as they carry a higher mortality rate. Negative pressure wound therapy, also known as VAC, is a wound dressing system that continuously or intermittently applies subatmospheric pressure. It improves the wound environment through direct and indirect effects, which accelerate healing and reduce time to wound closure. So, sequence. On admission at the ER, September 20, hospital day 5, hospital day 15 after the first NPWT change, day 17, the second NPWT change, day 20, the third NPWT change, day 33, preparing for skin grafting, skin graft late, day 28, first graft site inspection. First, graft site inspection on hospital day 38. The spaces between the graft have begun to epithelialize. And day 46, second graft site inspection. Day 48, on the date of discharge. This was the patient's skin graft last December 2, 2021, 1 month after discharge, or what would have been hospital day 73. The graft is well healed and had good take. For comparison, September 20, 2021. December 2021. September 2021. So some learning points, lessons learned, recommendations. The presenting signs of cervical necrotizing fasciitis may mimic deep neck abscesses. You always have to maintain a sense of urgency because the risk for mediastinitis is real and it carries a higher mortality rate. Surgical debridement is the mainstay, which may be done more than once. So initially we wanted to drain all the pockets in the first OR, but we would go past the allowable blood loss, so we had to take a step back and fight another day. And low-cost NPWT is a viable option for addressing infected neck wounds. And some nuances during the management. We didn't have a wall suction available due to room availability problems, so the regimen for this schedule was only empirical based on the available literature. 60 minutes on and 60 minutes off. And for the traditional back, the pressure is usually 100 to 120 mmHg, but we could not measure that using the portable suction. Another problem we encountered was the irregular surface of the neck as opposed to the extremities, where this is usually used, the back, which made it difficult to contour the seal. So to optimize, the skin was made sure that it was dry. The patient was advised to lie only in one position during sleep. We attempted to remedy this by placing a cervical collar around the patient. And although it would be probably be impossible or difficult, it would be interesting to see how a wound dressing system like this compares to the commercially available ones. And most importantly, address the underlying cause. We emphasize to the patient good control of his diabetes mellitus. And we also involved the removal of the dentition because, again, as mentioned, odontogenic causes are the most common cause of necrotizing fasciitis. So I'd like to acknowledge Dr. E, my friend and co-resident, who was also involved in managing this case, as well as Dr. Catherine with Dr. Ronaldo Reyes and Dr. Arsenio Clara Pumcal, our advisors who are currently in the Philippines. And I'd also like to thank our consultant, Dr. Ricardo, and my friend, Dr. Kevin David, for being in the audience. Thank you.